this type of lung cancer, or any other kind of lung cancer, can have the patient filling up with fluid and end up having a pleural effusion. Just so you know the different terms, you could probably write them on that sheet. They're real easy and quick. Lung cancer, obviously the number one way to get adenocarcinoma is smoking. Mesothelioma is not related to smoking. It's related to environmental pollutants, chemicals, asbestos, I should say. But with this lung cancer, you remember 20 years or more, like a nice little guarantee of lung cancer, okay? Now, so 20 years or more, you remember pack years? You remember learning that in school, pack years? I should never assume. You guys are looking crazy. Let's do pack years. If I smoke 1 pack a day for 20 years, I have 20 pack years. Do we all agree? If I smoke 2 packs a day for 20 years, I actually have 40 pack years. If I smoke 1.5 packs a day times 20 years, I have 30 pack years. I have 1 for each one of these, which was 20, and then I have to cut it in half. So far, so good? Half of 20 is 10. We got no pack years. Okay? If I smoke half a pack a day for 20 years, I have 10 pack years. So what we're saying is we don't say 20 years. We say if you got 20 pack years, you're guaranteed to die from this lung cancer. I mean, it's just like, okay, which way am I going to die? Let's pick this one for that person. Okay? All right, now, so 20 pack years, pretty guaranteed. And what happens with that patient is we have to decide how to treat them. This is not hard. Lobectomy, a lobe. Pneumectomy, the whole damn lung. The two you got to worry about is wedge resection. Wedge resection. Wedge resection is not going to be a type of treatment. It's going to be a type of biopsy. So it's as if I took a wedge of the lung out. That's what it is. A wedge resection. This was in no way meaning to treat shit, because you ain't getting nothing. All you're doing is trying to stage the cancer. Don't that make sense? Now, a wedge resection is often done through a procedure called VATS, video assisted thoracotomy. Any kind of whatever you did to the lung is a thoracotomy. Whatever you did, because you cut into the lung, which is all cotomy meant. Thoracotomy. Cut into the chest cavity to get to the lung. Everything is done through a thoracotomy. Video assisted thoracotomy is the most common. Both papas had it. Okay, now, if I do a segmented resection, I didn't take the whole lobe out. I took a section of a lobe out. And this would be done trying to decrease the size of the tumor or some crap like that. Don't forget there's no cure. I have wonderful people who survived the bullshit, but there is no cure. In other words, when we list your cause of death, it's usually that. Unless you have a little lovely miracle going on, which I love miracles. They prove that we're not in charge of shit. And there's miracles every day. You have to believe if you don't do anything else in this field. But for 99.99% of the people, there's no cure. So essentially, this is going to be their cause of death. What there is instead, which is what we did with Papa, because they gave him 6 months without any chemo, that would be his death day, roughly, or they gave him 18 months with chemo, and he told Dr. Helmos, I want to live, now make it happen. And he did live 5 years. But his cause of death was lung cancer, okay? So you're going to remember that. That's common sense, okay? So that's fine. Now, laryngectomy is the last little crazy thing on this side anyway. I told you to write this down. Did everybody write this down already? 100% of the Tri-C babies. I can erase it then. Now, laryngeal cancer. You know that there's so many different kinds. You don't give a shit about all that. You care about the 2 different kinds. I'm going to tell you what you care about. You care about supraglottic and total. Supraglottic, laryngectomy, and total. You care about those 2. First of all, when a patient has laryngeal cancer, it's cancer of the voice box. So if you have common sense and you look at that board and you say, oh, they did a total laryngectomy. Well, shit, they took out the whole voice box. So can you talk? No, so that's not bad. That's okay. You can work that one out. Okay, so you took out the whole damn voice box, so your little ass can't talk and say shit. Okay, now supraglottic is a partial laryngectomy. Partial laryngectomy. The whole reason we did a partial or supraglottic was to preserve the voice. You might want to quote me on that. The whole reason we did a partial was to preserve the voice. The other word for partial is supraglottic. Now, so with this patient, first of all, when we're looking to see what is the number 1 symptom, it's hoarseness. Hoarseness is early on. Patient is hoarse. They may have something on your test, any test that you would take, but certainly your final. Leukoplakia. What the hell is that? What's leukoplakia, y'all? White patches in the mouth. Painless white patches in the mouth. Is on the other side of the board. The board over there has it on there. Leukoplakia is over there on that side of the board. Erythroplakia is red velvety patches, but this patient has leukoplakia. White, painless patches. They're hoarse. Auntie sound like uncle. They have a, what is it? They have a lump in their throat when they go to swallow. A lump in their throat. This is seen more in men. The spokesperson I tell you to remember is Michael Douglas, because that's what he got. It's for patients who are alcoholics, smoking, HPV, chewing tobacco. Don't forget that HPV on your exam. So smoking, drinking, chewing tobacco, HPV. Use your imagination for that one. When this patient comes in and they have laryngeal cancer, we already know that they're going to have radiation at some point. Radiation, we know that they're going to have surgery. The radiation, I want you to remember, is localized symptoms. If I direct radiation at my face, throat, brain, whatever, if I direct it at my face, brain, throat, whatever, then I'm going to literally have drying and burning of everything in its path. So I'm going to have a dry mouth. That's called xerostoma. X-E-R-O, xerostoma. I'm going to have mouth sores, literally open lesions from the burning of tissue in my mouth. Mouth sores are called stomatitis. I may have thrush, which is mucositis. Mucositis, thrush. I may have a cracked tooth. A cracked tooth. Okay, so whatever the deal is, somewhere along the way, either before surgery or after, I'm going to have radiation. Surgery, let's deal with the supraglottic first. The reason it was done, and I told you to quote me, was to preserve the voice. However, this patient is at very high risk for aspiration. Such high risk for aspiration that you had to remember the chin tuck technique for eating. And what I tell you, if you forget, because you're human, on the test, what the hell were you doing with this patient? If you go like this, you can't swallow. If you go like this, you can swallow. Chin tuck, tuck the chin. You sure as hell can't do a damn thing if you're doing this. Okay, so this patient gets dysphagia precautions. When they come out of the OR following surgery, they're not going to be able to talk. So you have to provide some way of talking for them, a magic slate board, a dry erase board, whatever you want to call it. They're going to need their oxygen humidified till the day they die. So if they ever get oxygen, it has to be humidified. They're going to need an NG tube for 10 days or more. So NG tube for 10 days or more. A ventilator is mandatory. This patient with this trach on a vent, you're going to keep an extra, what we call obturator, handy. So you're going to keep an extra obturator at the bedside. This obturator needs to be a size smaller than the one that's in the patient. Because if they decannulate, it's a medical emergency that first week. Never ever can they get it wet. So no swimming. No powders or sprays should be around them, like baby powder or cornstarch or baking a cake with flour or aerosol deodorizers or sprays of any sort. No sprays, no powders. They need a smoke detector because they can't smell anymore very well. There's something called a supraglottic swallow that you were supposed to know how to teach. For this, the patient needs to be sitting up in a 90-degree angle. You need to have the patient clear their throat. They need to take in a deep breath. They have to take in small bites, no bigger than a half a teaspoon. They're holding their breath and doing this sound. We call it gulp eating. Just like that. So they're bearing down and they're basically gulping. They're doing a Valsalva maneuver during this gulping, and they are told to swallow 2 to 3 times after that exercise. So just keep trying to swallow. The supraglottic laryngectomy, remember with their trach, when you deflate the cuff, they can talk. Quote me. When you deflate the cuff, they can talk. You want to also make sure you suction the patient after deflating the cuff. Quote me. Suction the patient after you deflate the cuff. The most important thing you can do with this patient post-op, cough, deep breathe, and reposition frequently. Cough, deep breathe, reposition frequently. Comfort measures for the patient if they had radiation. You're going to make sure they know they can't shave, and this is a big deal for guys. They cannot shave. They can use ice chips. They can suck on ice chips. Saline gargles. Their throat hurts, so they can have lidocaine spray. We should be pushing fluids. We tell the patient they may have neck burns and that they will have permanent xerostoma, which is dry mouth. It'll be permanent, so they need artificial saliva. Now, the total laryngectomy with regards to how should they speak, put in your notes, esophageal speech for total laryngectomy. Esophageal speech, this is where you swallow the air. You swallow the air and you burp while you shape your mouth. So it's called burp talk. So you swallow the air and you burp while shaping your mouth to make words.